Welcome everyone. Thank you for joining us in today's webinar. I would like to open the first session of the event today. I will chair this session with Professor Marsha Morgan together. The topic of this session is epidemiology and pathogenesis of the DILI. Yes, Professor Morgan.
Hello. The first speaker today is going to be Jane Groves, who is from Nottingham, and she's going to talk to us about this very exciting venture.
Welcome everyone. Thank you for joining us in today's webinar. Welcome everyone.
Hi.
Thank you for joining us in today's webinar. I would like to open the session of the today.
It's such a great programme of talks about. It's a great pleasure to be giving the first talk at this meeting. It's such a great programme of talks about DILI. I'm very grateful to have this opportunity to talk to you about the Pro-Euro DILI Network Registry. I hope to set the scene, defining the challenges, and explain how we can address these through collaboration to create a valuable resource for academic, clinical, and industry researchers. This is my declaration statement. You are all probably very familiar with the effects of idiosyncratic DILI. Despite its rarity affecting only about 20 per 100,000, idiosyncratic DILI accounts for up to 15% of acute liver failure clinical cases. And in fact, its incidence is substantially higher in people taking certain common medications, for instance, being about twice this rate in users of amoxiclav. Also, hepatotoxicity is a common cause of drug attrition during development and is the most frequent reason for the market withdrawal of an approved drug. We know that DILI occurs in association with a large number of drugs and shows heterogeneity in clinical presentation and outcomes. On top of that, the symptoms resemble that of other common diseases, making it difficult to diagnose quickly. Our challenge is to find the markers that can be used to effectively preempt and prevent DILI, and which can be used to monitor the severity and course of the adverse event. The rarity of DILI means the only viable approach is to work collaboratively to develop a large database and sample set to investigate and address these challenges. Thus, the Pro-Euro DILI network was established with a goal of creating a deeply phenotyped and documented DILI case cohort for biomarker development, for validation of clinical biomarkers, and development of safety biomarkers. Underpinning these objectives, we have set up an international registry. This means we have consistency in definitions and classifications and have harmonised clinical tests and measurements. And we follow standardised processing procedures, enabling our research studies. First, it's crucial to have an agreed clinical definition. Liver enzyme results of ALT 5 times the upper limit of normal, or ALP twice the upper limit of normal, or else a combination of ALT 3 times the upper limit of normal and total bilirubin twice upper limit of normal are key features now defined as the EASL criteria, along with drug exposure and exclusion of alternate causes. Second, we have developed a unified study design for a case control study for patients during onset and until resolution. This has been built collaboratively from our experience of existing studies and registries, through consultation with patients, nurses, clinicians, researchers, and industry partners. So we now have a process pipeline in place for setup and training at sites and for study delivery. The research pathway for the registry is closely aligned with standard clinical care for practical reasons and for patient consideration. We start with the identification of a person presenting with symptoms suggestive of a possible adverse reaction affecting liver function in response to a medication or supplement. This can be at a clinic visit or at emergency admission. The research team are informed and they review the case and any test results available to determine if the LFTs are likely to meet the DILI criteria. This is often on the same day or the following day. Obviously, we can't predict when these cases will arise, and we hope the patient will quickly start to recover once they stop taking the medication. So this requires the research team to be very responsive at short notice. Once consented, where possible, research samples are collected at the same time as clinical blood tests. Routine blood tests and investigations done as part of clinical care are documented as part of the study, so no additional costs are associated with the research pathway. Once the clinical test data is available, we review the case and determine if the participant met the DILI liver enzyme inclusion criteria. If so, we continue with sampling, as I'll explain on the next slide. We continue to follow patient investigations and outcomes. Then, when the clinical care pathway is completed, the case is reviewed by an international expert panel who adjudicate and determine the diagnosis classification, which I'll explain in a moment. This explains the study visit arrangement. We have the onset visit at recruitment, that's visit 1. Then patients return after 1 week for visit 2, and a month later for visit 3, as standard. However, where patients are admitted for serious symptoms, we have an option to obtain further samples in the following days, so we can follow the disease course, which may initially worsen before recovery. Also, in cases where the liver enzymes have not normalised after 1 month, that is by visit 3, we schedule a later visit to reassess recovery. This is visit 4 after 3 months. And again, we follow up after 6 months if the enzymes are still raised. The sample dates are quite flexible, so it can be accommodated into the care pathway as far as possible. We hold monthly meetings for case review and classification by expert panel consensus. Cases where the clinical workup reveals an alternate cause of acute liver failure are designated as non-DILI cases. The workup would entail investigation of viral hepatology status, features of autoimmune hepatitis, or other acute injury which may explain the clinical manifestation. Also, workup would need to establish if there is evidence of acute exacerbation of existing chronic disease or any biliary obstruction explaining cholestasis. Then, any other suspected factors potentially responsible for the event based on the patient history and clinical judgment. Our recruitment target is to have 300 cases of confirmed DILI and 130 non-DILI cases by April 2024. In Nottingham, we opened recruitment in February 2016 and now have 130 enrolled, so it's around 2 cases per month. This includes a full spectrum of disease severity as we have approval for consent by consultee where cases lack capacity. The current number of suspected DILI cases recruited across all 23 centres totals 472. Of these, 303 have been adjudicated. This has identified 172 DILI cases and 69 non-DILI acute liver failure controls. So we're about halfway to our target. You can see we do get a high number of exclusions where cases are found to have an uncertain cause or incomplete investigations, or where there is no agreement across the panel. This process is crucial to ensure the classification is accurate so that our biomarker studies are robust. This slide gives an overview of the samples collected and the processing, which ensures we have the best results available for research. Separate aliquots are kept so multiple projects can be done while preserving sample integrity, avoiding freeze-thaw cycles. We have optional sampling sets, which allow sites to fit in sampling with their lab procedures and local facilities. Serum is stored for protein biomarkers, for validation of markers identified by earlier projects, for example, CK18 and osteopontin. Also, we're able to do metabolic profiling of small molecules and lipids in serum samples. Similarly, Urine samples can be used for small molecule and protein biomarker tests. Stool is kept for microbiome studies. We also collect an EDTA blood sample for determination and storage so that DNA can be extracted, as we know that genetic factors can be important from our previous GWAS studies. Plasma is also prepared from the EDTA blood for determination of biomarkers. Protocol processing time is limited and temperature controlled to preserve these biomarkers. We specifically use a high-speed centrifugation step to deplete platelets, so samples are suitable for high-sensitivity microRNA analysis because platelet-derived microRNAs can affect measurement of low-abundant species. Collection of a sodium heparin blood sample is also recommended for isolation of white blood cells, such as peripheral blood monocytes. These samples can be used for deep immune phenotyping by traditional flow cytometry techniques or by mass spec, which I'll describe in a moment. Also, sorted cell groups can be subjected to single-cell RNA-seq to give us an immune cell transcriptomic data set. An alternative is to use the preservative PAX gene sample tubes to collect samples for bulk transcriptomics. Where cases are investigated via liver biopsy pathology, we include procedures for collection of surplus diagnostic material, either as FFPE samples or as fresh material, snap frozen or in RNA later, whenever it's feasible to collect tissue at the time of biopsy. This means material may be available for traditional microscopy imaging approaches or for sophisticated analysis of cells isolated from the tissue. So this will provide the necessary mechanistic information from the liver resident immune cell population and its interconnection with the circulating immune phenotype. So just to explain CyTOF for those of you who are unfamiliar, it's similar to FACS flow cytometry, where antibody panels are used to identify cell markers. But in this case, the tags are heavy metals. This has the advantage of avoiding autofluorescence issues and signal overlap. Their mass spectrometry time of flight methodology generates ions, which are separated and then detected and processed, so you get a readout of marker quantity per cell. This can then be visualized graphically. The advantages are that you can use a larger antibody panel and only a small sample size is needed, as little as 0.5 ml is enough. The processing is fairly straightforward, although you do need to stay in the cells fresh, but they can then be stored frozen and transferred to the CyTOF machine. However, mass spec assays are costly and labour intensive, so are not readily translatable. We're using the MaxPar direct immune profiling assay from Fluidigm, which is well established and validated. It requires about 1 million cells, which are labelled with 30 different antibody conjugates listed here, and iridium dye, which identifies the live cells. From this, 37 different cell types can be identified and quantified, including B cells and T cell types. For example, the markers used can discriminate the CD3 negative B cell types from monocytes, dendritic cell types, and the NK cell types. And similarly, the CD3 positive T cell subtypes can be separated out as shown on this diagram. PathSetter software is available, which automatically processes the raw data components into supervised clusters, which are assigned to immune cell types based on the markers and median metal intensity. So the intensity measures for all 30 markers are collapsed onto 2 axes in these sense-E plots, which visualize the immune cell composition, so you can easily compare individuals or patient groups. You can see separate clusters for CD4 positive, CD8 positive, T cell types, B cells, and NK cells. For the ProEuroDILI registry, in order to collate the patient phenotype, an electronic database was developed, which acts as an ECRF, collating the anonymised case information. So we have the usual demographics, risk factors, comorbidities and meds, then samples and onset information, and the relevant blood test results, and where possible, any data available from prior to the acute event. We also have a full description of the disease course and investigations until an outcome is reached. The data is cross-checked at the adjudication phase, so it is accurate with the clinical overview and paper case report form. Also, the data management system calculates the SEOMS and RUCAM scores and collates the adjudication decision. This is then linked to the samples collected and stored, which are available for assays. This is what the database entry looks like. At a glance, you can see the causal drugs, scores, and then you have separate tabs for each data type and across each sample visit. To summarise then, in order to tackle the challenges of investigating DILI, teams across Europe are working together to create a large cohort needed for robust research. This has involved the creation of the Pro-Euro-DILI network, which has been facilitated by cost action funding. This is our website. The Pro-Euro-DILI registry has been set up for consistent data and sample collection, cataloguing and management. In particular, the expert panel review and classification of every case ensures a very high quality case control cohort is created for analysis. This means we can now begin to make headway with vital research to understand the disease mechanism and identify biomarkers for clinical practice and for drug-safe marker development pipelines. This lists the current active registry partners in the UK and at centres in Europe. If you're interested in connecting with us, please do talk to Guru or contact me via my email shown on here. We really welcome new partners and are happy to share our protocols. Finally, I acknowledge the funding support listed here. And I acknowledge the registry founders, Guru and Raul, who set up this funding with the EASL registry grant. I'd like to acknowledge the group members in Nottingham and Malaga, particularly Camilla, who's responsible for data management, and Edmund, who's been recruiting at Nottingham. And also the TransBioline Consortium Partnership, who we're currently working with to develop safety biomarkers. Thank you for listening, and do please get in touch if you're interested in being part of the network.
If you have any question, please type them into the question box in your control panel or chat me, and we will bring them up during the presentation, and we will also have time for the question at the end of the session. And I would like to invite the second speaker, Marsha Zeybel. As you know, that TASL has several special interest groups. One of them, the DILI. Marsha is the coordinator of the DILI special interest group, and he will present the DILI database of the TASL. Yes, Marsha.
Good morning, everyone. My name is Marsha Zeybel. My task is to outline epidemiology of hepatotoxicity in Turkey and also discuss Turkish Association for the Study of Liver Hepatotoxicity database. So my presentation outline will be two parts. The first part will be about the epidemiology. What are the local differences? What are the differences in terms of drugs associated with hepatotoxicity in Turkey? And I will briefly explain our national regulations and guidelines which are affecting the outcome in terms of DILI. And in second part, I will talk about our efforts in establishing hepatotoxicity registry and biobank in Turkey. So drug-induced liver injury is the second common cause of acute liver failure in Turkey, and it is becoming more and more common. There are several reasons. One of them, in Turkey, prescription medications are not strictly regulated, or it wasn't before. It's becoming more and more, but basically 5 or 6 years ago, you were able to go to pharmacy and get Coamex Club or antibiotic without prescription. And over-the-counter medications are quite common. Another issue in terms of herbal or supplement-induced medications, this is not regulated by drug department. It resembles to American structure. It is regulated by Food and Agriculture Department. So this is a big issue. Also, polypharmacy is getting more and more coming due to aging population in Turkey. I think it's very difficult to report the incidents everywhere in the world, but in Turkey, we have some issues with underreporting of drug-induced liver injury. What are the other challenges? I should say these are the challenges, maybe similar to the UK or Europe, but some of the challenges having more implications in Turkey, maybe slightly due to resources limited. One of them is diagnostic criteria. It's too complicated. It requires several lab and imaging tests, and it is not always available in every center in Turkey. Other problem, this is a low incidence condition. In order to generate a data and develop some experience, it is unlikely that you can do in a single center anyways, but the collaboration is necessary. Another problem, even single agent can present with different pictures. So there is no specific presentation for many agents. And obviously, we still lack of objective, reproducible diagnostic tests for drug-induced liver injury. Let's be more specific. What are the common causes of DILI in Turkey? First, start with the UK data from King's College 2009, presenting the causes of acute liver failure in the UK. This orange bar is representing paracetamol overdose, and the second cause is autoimmune. And here, as a last cause, is the third cause, is the drug-induced liver injury. Let's look at another transplant center from Turkey. Data is quite different. This blue bar is representing the viral hepatitis-related acute liver failure, which is still quite common, although after the hepatitis B vaccination program, Hep B is going down, and Hep A's are also settling, but still we see cases. And the second cause after viral hepatitis is the drug-induced liver injury, which is nearly double of what you see in the UK. And the third cause here, another cause here, let's say, is intoxication due to, for instance, mushroom poisoning and other causes. So it's quite different in terms of paracetamol overdose. When I showed this data to Prof. Aytal, he thought that, oh, it makes sense. People in Turkey more happy, they don't even commit suicide. I wish that was the case, but unfortunately it is not. We believe the reason for this is we don't have paracetamol capsules as common as UK. Most of the paracetamol is provided as tablets in the Turkey. I believe it would be very difficult to swallow many tablets because of the taste. Probably it would also cause nausea and vomiting. There might be some cultural differences as well, but we rarely see paracetamol overdose and related acute liver failure in Turkey. So what are the usual suspects in terms of medications? Here we got antibiotics. This is the data from Ankara University in Ankara, and this is Dylan data from United States. Basically, antibiotics and antimicrobials are quite similar here, but when we look at the details, yes, Comax Clav is similar in the both cohorts, but we got ornidazole here is a second common cause of antibiotic-related DILI. Ornidazole, I'm not sure if it is available in the UK, but it was introduced much before to Turkey than metronidazole, and it is commonly prescribed by surgeons, gynecologists, and GPs. And interesting, I think there is another presentation in this meeting. It causes drug-induced liver injury and probably some autoimmune hepatitis as well. When we look at the other data, we have nitrofurantoin and cotrimoxazole in the US database. We can't see here. The reason is Turkish microbiology and infectious disease guidelines for urinary tract infection. Nitrofurantoin and cotrimoxazole is not recommended. Instead, quinolones are recommended, and you see the high number of quinolone-related drug-induced liver injury. And when we look at the other causes, basically non-steroid anti-inflammatory medications is quite high compared to US data. We think this is due to two reasons. One of them is we have a variety of painkillers compared, and we still use diclofenac, for instance. It is very well established cause of drug-induced liver injury, and probably opiates are underused, and still non-steroid anti-inflammatory drugs are more commonly used in Turkey. What about herbal and supplement-induced liver injury? I think it is clear that it is going more and more common in Europe, in the UK, and United States. This is Spanish database. In Turkey, I found a publication which is suggesting 12% of the cases due to herbal or supplement-induced. I believe this is slightly underrepresented because of the regulations and easy to have access to supplements and medications. I believe we are seeing more cases compared to this report. Another interesting thing, as you see, most of the data is coming from transplant centers, and we have some different approach in terms of, or the different practices in terms of a liver transplant in Turkey. This graph is showing the number of liver transplants per year. I think it's 2018. It was published in 2020. Turkey is with the highest number of liver transplants in all Europe. And this is mainly related with living donor-related liver transplant. So the data that I'm showing probably may underrepresent or overrepresent drug-induced liver injury as a cause of acute liver failure, because we have easier access to liver transplant compared to our European and UK colleagues. In order to overcome the problem that we have lack of established data for hepatotoxicity, in 2018, we established hepatotoxicity working group in TASL. We aim to establish our registry, identify the common causes, increase the awareness, and also establish some safety measures and share this data with our local regulatory authorities and also facilitate hepatotoxicity research in Turkey. There were three main objectives. One was to establish this nationwide prospective registry, and second one to create a biobank, and the last one to get funding from national and international funding bodies for DILI research. We started with reviewing previous registries. In this aspect, Prof. Aytal was very helpful. He basically shared what type of information they are gathering in Pro-Euro-DILI, and our registry is resembling Pro-Euro-DILI for many aspects. We are collecting prospective, we are recruiting prospective cases, and also patients who had injury in the past 6 months. And also we are having controls exposed to the similar medications without any liver injury. And we are having 6-month follow-up and report outcomes. We have specific focus to some medications like Comex Club or nitazole, quinolones, TB medications, and mushroom poisoning, but it is not restricted with these agents. We also get information regarding others. So we would like to identify our national characteristics of DILI, and Turkey is a big country with some geographic and ethnic variation. I believe also there is some clinical variation in clinical practices. It will be very important to gather this information. And we would like to establish our natural history from this drug-induced liver injury cohort, and we will discuss this with our local authorities. Basically, when you go to electronic or online case support form, you find baseline demographics first, age, gender, and other things. And afterwards, on the first page, you were asked to provide LFTs and your local upper limit of normal according to your laboratory, local laboratories. And our score is calculated automatically. Is it hepatocellular? Is it cholestatic or mixed type? And here we are providing some more information in terms of biochemical criteria for registration. Basically, this patient has, for instance, ALT of 274. If according to this criteria, the CRF calculates and think that this patient is suitable for registration in terms of biochemical requirements. And another case here is it is calculated and give some warning to user saying that this patient is not suitable. And in the second page, the website is asking you, is it drug, is it supplement, is it herbal, and what type of medication is this? Is it antiviral, antimicrobial, and what was the suspected medication? What was the dose, interval, route of the medication? And here, according to ICD code, it's asking the indication and when was it started, and are there any symptoms, nausea, vomiting, abdominal pain, fever, jaundice. And is there any underlying disease? Is patient, if you say yes, there's a scroll down menu, it's showing, is it NASH, is it alcohol-related liver disease, is it viral hepatitis, basically. And in the next page, it's asking the observations and date of the appointment or admission, and are there any allergic or immunological features, eosinophilia, rash, fever. It is also asking metabolic syndrome according to ATP3 criteria. And I think it is very important that we are seeing more patients with cancer, lymphoma, and underlying diseases such as diabetes, hypertension, you need to provide this information. And the next page, investigations. What are the radiological investigations, if there are any, and any biopsies? I should say we do have less biopsy for drug-induced liver injury in Turkey. This may be particularly related with access to transjugular liver biopsy. It is not available every center, and it is probably limiting in severe drug-induced liver injury. And what about outcomes? We report here recovery, transplant, or death. And this is, I think, another point that we need to discuss in symposium. It is also a bit related with underuse of liver biopsy for differentiating drug-induced liver injury from autoimmune hepatitis. I think it's more common to see patients had steroids in Turkey, and also it's probably more widely used for cholestatic type of DLE or mixed type of DLE in Turkey. And it's also asking here ward or intensive care admission and how long you can provide all the information. And I'm not showing here, but basically you are asked to provide the biochemical and all data and details. And the last page is calculating RUCAM score on the basis of the data that you provided here. I think it is not essential, but we advise to provide this information. Basically, if it's hepatocellular or mixed type, according to this page is changing and giving the RUCAM score for this case. As a second objective of our efforts, we are also creating Turkish liver of association for the study of drug-induced liver injury biobank. We are collecting biological samples from these cases for further research. So this is my last slide. I'd like to thank working group members for their efforts in this project. So today was my last day as a lead of hepatotoxicity working group. Prof. Erçin will be the next lead for this group. We tried to work hard, and it was really a pleasure for me to be involved in this project. And by today, you will be as TASL members. You will be receiving emails regarding ethics application, and also link and the passwords regarding your registry. And once your center is involved in the ethics, then you will be able to record your cases and list your patients in this registry. Thank you for listening. Thanks very much.
Thank you, Müjdat, for your great presentation. Before I forward, I would like to kindly remind all colleagues and all participants, TASL-BASL registry is now ready and will be opened as soon as possible. And we would like to participate for your kind contribution. And next speaker is Professor Cemal Nuri Erçin. He's going to talk about the host and drug-dependent risk factor for hepatotoxicity. Yes, Nuri.
I would like to thank the organizing committee for giving me the chance of talking in this meeting. The topic is host and drug-dependent risk factors for hepatotoxicity. First, I will talk about host-dependent, then drug-dependent risk factors. Among the host-dependent risk factors, I will explain the details about age, sex, race, alcohol, pregnancy, and concomitant diseases. Let's begin with age. The incidence of serious adverse drug reactions has been reported to rise with increasing age. Let me give some examples about these data. In Spanish DILI registry, 33% of DILI patients were more than 65 years old. On the other hand, US DILI network showed that 16.6% of patients with DILI were 65 years or older. Also, we know that RUCM casualty assessment scale gives an extra point to cases involving patients above 55 years of age. The frequency of jaundice was highest in the older age in both the hepatocellular and cholestatic mixed group. Increase in medication use, dose, and impaired drug clearance may be the factors responsible for DILI in older people. Age appears to affect the risk of DILI induced by some agents. Isoniazid hepatotoxicity can be seen alone or combination with other antituberculosis drugs. In a study comparing the younger patients, hepatotoxicity was almost 5 times as many cases in patients more than 50 years old. The reason for this difference was explained by altered pharmacokinetics and or cumulative mitochondrial functional impairment. On the other hand, valproic acid is an important factor in childhood in terms of DILI. It's shown that children less than 10 years old had a high risk of developing DILI, and also children less than 2 had the highest risk of a fatal outcome, possibly due to the differences in drug metabolism and reduced plasma protein binding. Age also seems to have an effect on DILI phenotype. Younger patients more commonly develop hepatocellular injury, while older patients are more prone to a cholestatic pattern of injury and also clinically chronic DILI. Women are reported to have a higher risk of adverse drug reactions in general. Hepatocellular type of DILI has been shown to occur more commonly in female than male individuals. On the other hand, DILI cohorts from Spain, US, and Iceland showed relatively equal sex distribution. We know that minocycline, flucloxacillin, diclofenac, and frontoin-related adverse reactions were seen more frequently in women. These medicines, especially minocycline and frontoin, are accepted as responsible for DILI with autoimmune features, and also women are more susceptible to idiopathic autoimmune hepatitis. Lastly, women may have a higher risk of progressing to acute liver failure in DILI cases. Let's look at the effect of race in DILI cases. Chronicity, defined as elevated liver tests 6 months after presentation of DILI, was more common in African American individuals than in other races. Asian race was also an independent risk factor for the need for liver transplantation from DILI. A recent study, Drug-Induced Liver Injury Network Group, found that African American individuals had higher rates of liver-related death and liver transplantation at 6 months compared with Caucasians. The effect of ethnicity on drug susceptibility has been primarily attributed to variations in single nucleotide polymorphism. In a recent cohort study related to the relationship between DILI and the different ethnic groups showed that while amoxicillin clavulanate was a causative agent in a significantly higher proportion of Caucasians, trimethoprim sulfamethoxazole, methyl-dopa, and phenytoin were more often the cause of DILI among African Americans. Also, frequency of severe cutaneous reactions, the rates of hospitalization, and liver-related deaths was significantly higher in African Americans compared to Caucasians. Let's give some data about the studies related to drugs and genome-wide association studies. Amoxicillin clavulanate-induced DILI showed the strongest association with some HLA haplotypes, and one of them was seen only in cases of Northern Western European. One of the HLA allele is prevalent in only 0.7% of Caucasian populations, while its prevalence is higher among South Asians. A recent report has identified this allele as a potential risk factor for amoxicillin clavulanate-related fulminant hepatic failure requiring liver transplantation in individuals of South Asian origin. On the other hand, adverse cutaneous reactions to anticonvulsant drugs such as carbamazepine, phenytoin, and lamotrigine have been consistently associated with the same allele, especially among Asian patients. The data about the alcohol and DILI are contradictory. Although no specific level of consumption has been defined, RUCM casualty assessment scale gives an extra point to patients with a known history of alcohol. Alcohol is a recognized cytochrome inducer and is such of crucial importance in the formation of reactive metabolite responsible for acetaminophen hepatotoxicity. However, data that support alcohol as a risk factor for idiosyncratic DILI are only available for selected drugs such as isoniazid, methotrexate, and halothane. In a study, any alcohol use in the preceding 12 months was accepted as a negative predictor of severe DILI, but a more recent study of the effect of alcohol on DILI by DILI Network Group found that heavy alcohol consumption was not associated with worse outcomes in DILI patients compared to no alcohol consumption. Lastly, anabolic steroids were found to be the most common cause of DILI among the heavy drinkers. Although the inclusion of pregnancy as a risk factor for cholestatic mixed type of DILI in a RUCUM causality assessment scale, there is limited data about the relationship between DILI and pregnancy. Presentation was usually in the first 20 weeks of gestation, following a latency of several weeks, because these drugs were usually prescribed before or in early pregnancy due to their fatal safety. The hepatotoxicity is usually of idiosyncratic form, and most would resolve spontaneously, although occasional liver transplantation and maternal death were reported. Because of having a similar clinical findings, it is important to distinguish DILI during pregnancy from intrahepatic cholestasis of pregnancy. Information on DILI in pregnant women is mainly restricted to antihypertensive agents such as methyl-dopa and hydralazine, antihyperthyroidism agents, propyluracil, and antimicrobials, in particular tetracycline and antiretroviral agents. Tetracycline is currently the only known drug for pregnancy to increase the risk of DILI development. Tetracycline can cause microvesicular steatosis of liver, in particular after taking large doses intravenously. Hepatotoxicity due to tetracycline, however, is not limited to pregnant women but has been reported for men. Tetracycline depresses cell anabolism by interfering with protein synthesis, inhibiting acetate metabolism, and impairing oxidative phosphorylation. Comorbidity. Although we know the effect of ongoing inflammation as a co-stimulator during DILI, there is limited evidence to support or refuse the role of comorbidities in susceptibility to acute DILI. Diabetes mellitus does not seem to increase the risk for DILI in general, but has also been associated with increased risk of mortality in patients with DILI. To explain the effect of comorbidities in DILI, we should review the concept drug-associated fatty liver disease. In this scenario, drugs and the other factors responsible for the pathogenesis and progression of liver disease work together. There are two examples here, tamoxifen and methotrexate. In a multi-center study including more than 5,000 women, tamoxifen therapy was shown as a risk factor of developing fatty liver, especially overweight and obese subjects. The risk was twofold and increased in the first 2 years of treatment. In a breast cancer registry, including patients with NASH, tamoxifen usage had increased the risk of developing NASH by 8.2-fold, and the liver enzymes normalized after stopping the treatment in the majority of patients. Methotrexate-associated fatty liver disease and its severity has also been associated with alcohol excess, type 2 diabetes, and obesity. In another study among the patients being listed for transplantation, methotrexate-related liver disease was found 0.07% and demonstrated that obesity and type 2 diabetes were associated with these patients. Theoretically, the sense of chronic liver disease may be associated with reduced metabolism and clearance of medications and cause DILI, but this is not supported by evidence. Although patients with chronic liver disease do not in general have increased risk of developing DILI, the consequences of a DILI in these patients might be more severe. In DILI Network prospective study published 2015, they followed more than 1,000 patients, included 10% had pre-existing liver disease, mainly chronic hepatitis C or raised liver enzymes. Azithromycin was found as the implicated agent in a higher proportion of patients with pre-existing liver disease compared to those without liver disease. Mortality was significantly higher in those with chronic liver disease compared to those without. We can give some examples of patients with viral hepatitis taking anti-tuberculosis drugs. In a retrospective study involving more than 300 patients, including patients with chronic viral hepatitis, HCV with or without HBV was associated with increased incidence of DILI. Among patients with HIV infection using anti-tuberculosis treatment, risk of DILI was shown to increase by 4-fold, but co-infection with HCV increases this risk by 14-fold. In another cohort, including 107 patients with chronic liver disease, 17% of patients experienced DILI, with 24% of them were chronic hepatitis and 15% with compensated cirrhosis. Let's move on with drug-dependent risk factors. In this part, we will talk about those: hepatic drug metabolism, lipophilicity, concomitant drugs, and special chemical moieties in drugs. Drug dose is important, especially in intrinsic DILI. The classic example for this situation is acetaminophen hepatotoxicity, characterized by taking acetaminophen overdose. Idiosyncratic DILI, which occurs after drug treatment at recommended daily dose, previously was evaluated as dose-independent reaction. In 2008, the role of drug dose in idiosyncratic DILI was first demonstrated in a study from Swedish DILI cases. They found that 77% of cases involved a causative agent given at a dose more than 50 mg per day. This data was supported by Spanish DILI registry and a nationwide Icelandic DILI study. On the other hand, today, giving a dose limit is difficult because most of the pharmaceuticals, especially antibiotics, require a dosage of more than 50 mg per day to have a desired effect. But we still need a threshold dose to be exceeded for the reaction to occur in idiosyncratic DILI, but the dose may vary among individuals. Sometimes, in clinical practice, a patient tolerates a drug at an initial lower concentration but develops DILI when the dose increase is required within the recommended daily dose range. Lastly, it was shown that if the daily dose is higher than 50 mg, latency period is shorter than DILI induced by drugs taken at lower doses. Hepatic drug metabolism is an important factor for the drug's hepatotoxicity potential. During hepatic elimination, some form of biotransformation occurs, and this results in production of active pharmaceutical ingredients. The formation of reactive metabolites may stimulate the development of an adaptive immune response, resulting DILI. An analysis of more than 200 widely prescribed oral medications in the US showed that drugs with significant hepatic metabolism, meaning more than 50%, had a higher frequency of ALT elevations and liver failure. And also, in parallel with the data in previous slide about idiosyncratic DILI, drugs with significant hepatic metabolism and a daily dose of more than 50 mg were found to have a significantly greater risk of hepatotoxicity. Lipophilicity is one of the factors that affects drug-related toxicity. It is measured as the log of octanol water partition coefficient and shown as log P. If a drug's lipophilicity is high, the probability of toxic events are high. The role of drug's lipophilicity in DILI was speculated that higher lipophilicity could facilitate drug uptake into hepatocytes and metabolism. Log P may simply be a surrogate marker for extensive biotransformation and hepatic exposure to reactive metabolites. Rule of 2 reflects a drug's hepatotoxic potential. Based on an analysis of 164 approved medication in the US, high lipophilicity, meaning log P, more than 3 and more than 100 mg daily dose, were found as increased risk of DILI. The potential applicability of Rule of 2 as a predictive tool for hepatotoxicity has been demonstrated on direct-acting antiviral medications for chronic HCV infection, but in another study analyzing 975 oral drugs, was not able to confirm the prognostic ability of drug lipophilicity and combined with daily dose. One of the main problems in polymedicated patients in DILI episodes is to determine the most likely causative agent. Concomitant medications can also affect DILI susceptibility through drug-drug interactions. Concomitant drugs are capable of modulating the metabolism of other drugs through induction, inhibition, or substrate competition. Let's give some examples to this situation. Rifampicin has been demonstrated to increase the incidence of hepatotoxicity when given together with isoniazid as an antituberculosis treatment. Concomitant usage cytochrome enzyme-inducing anticoagulant drugs such as carbamazepine or phenytoin has also been reported to increase the risk of valproic acid hepatotoxicity. Not all the time, one drug exacerbates the effect of other in terms of hepatotoxicity. In an analysis of more than 700 Spanish patients with DILI, in patients with dyslipidemia, using statin has provided a protective effect against progression to acute liver failure. Reactive metabolites are known risk factors for the onset of DILI. Formation of reactive metabolites is assessed by covalent protein binding. Covalent binding may alter the function and location of the target protein or form neoantigens. In this way, reactive metabolites can modify the functionality and structure of cellular proteins. Direct toxins to hepatocytes induce oxidative organelle stress such as endoplasmic reticulum and mitochondrial stress, leading to apoptosis or necrosis. Besides their direct toxic effect, reactive metabolites are considered a first step in the onset of idiosyncratic DILI. Let's give some examples to this mechanism. Among the non-steroidal anti-inflammatory drugs, diclofenac causes severe hepatotoxicity due to the formation of reactive metabolites in two different ways. On the other hand, it's shown that the hepatotoxicity of ibuprofen and naproxen was related to glucuronidation of the carboxylic acid moiety to acylglucuronides. Other hepatotoxic drugs that form reactive metabolites are shown here. Mitochondrial toxicity is characterized by microvesicular fatty liver. Microvesicular steatosis is seen with amiodarone, valproate, tetracycline, and various antiviral nucleoside analogs. It is characterized by reduced numbers of mitochondria. Patients show hypoglycemia, hyperammonemia, and lactic acidosis, but only mildly elevated levels of ALT. Reye syndrome is characterized by a liver injury combined with acute encephalopathy. It occurs in children having a viral infection such as influenza or varicella and treated with acetylsalicylic acid. Acetylsalicylic acid can inhibit mitochondrial fatty acid oxidation, resulting in mainly microvesicular steatosis. Droglitazone, nefozodone, and benzbromomarone are known mitochondrial toxicants, but at the same time, they inhibit bile salt export pump. It is known that drugs with dual potential like these were highly associated with more severe human DILI and appeared more sensitive to drug exposure. Bile acid transporter impairment was known as a potential mechanism of some liver disease, especially characterized by cholestasis. So, some drugs and their metabolites cause DILI by inhibiting bile salt export pump. A well-characterized BSEP inhibitor is the endothelin receptor antagonist bosentan, approved for pulmonary hypertension. Cyclosporin A is also a potent BSEP inhibitor and is associated with drug-induced cholestasis in clinical practice. The major metabolite of the antidiabetic drug troglitazone sulfate, has a high potential to competitively inhibit BSEP and accumulate in hepatocytes. As a conclusion, age appears to affect the risk of DILI induced by some agents and also seems to have an effect on DILI phenotype. Female sex may be considered a risk factor for DILI, especially some specific drugs, and also associated with a greater risk of drug-induced acute liver failure. Ethnicity should be considered a risk factor for DILI. Regular alcohol intake may be a risk factor for DILI associated with specific drugs like isoniazid, methotrexate, and halotan. Tamoxifen and methotrexate treatment may cause DILI, especially in patients having components of metabolic syndrome in pregnancy. Presence of hepatitis B and C virus infection may be considered risk factor for DILI induced by anti-HIV and anti-tuberculosis therapy. A daily dose of more than 100 mg for any drug, cytochrome enzymes in hepatic metabolism, reactive metabolites, and dual inhibition of mitochondria and BSEP function may be the risk factors related to drugs. Thank you.
Thank you very much indeed for that excellent and comprehensive review, which will be useful for all of us. We'll now go on to our next speaker, Dr. Yi Wu from Birmingham, who's going to address us on the mechanisms of injury and immune-mediated reactions. Thank you very much, Yi.
Thank you very much, Marsha. And I'm from University of Birmingham. So today my job is to dissect the mechanism of drug-induced liver injury and how does the immune reaction happen. And I'm grateful to Guru and the organizing committee to allow us to present this data. So DILI, we feel that this is still a unmet clinical need. We still do not understand much about the pathogenesis. We do not have immune predictors. We do not have a proper stratified treatment pathway. So as previously mentioned by Simone, I think there could be a predictable and unpredictable types of DILI. Medication like paracetamol, then we can predict that these, if you take it more than what is recommended, we can get the DILI, and this is due to the direct hepatotoxicity of either drugs or its metabolites. And some of the drugs are unpredictable, and then the duration could be a bit delayed. For example, the best example might be the anti-tuberculous treatment and some of the antibiotic and the anti-epileptic drugs. So either immune-mediated reaction or idiosyncratic reactions are involved in both processes. So why does DILI affect the liver? Because all the drug metabolism are happening in the liver. That is one of the reasons that majority of the drug-induced liver injury present with the hepatitis. It can directly affect the hepatocytes and leading to the elevation in AST, ALT, or biliary epithelial cell, and presenting with a cholestatic injury. And then because of inflamed hepatocytes and biliary epithelia, and that will initiate the immune response. So as previously mentioned by Simone, I think when we had a drug injury, for example, I'll show as a hepatocyte as an example, we can cause the drug can cause many damages, not only to the cell membrane itself inside the organelles, and that will include mitochondrial, endoplasmic reticulum, and all the endosome. And that lead to the activation of the different pathway, including the tumor necrosis factor pathway, and leading to the cell apoptosis, necrosis, or cell death, and that will attract the innate adaptive immune cells. So we already heard from the previous speakers that there will be different types of liver injury. Some of the DILI present with acute hepatitis. There are some drugs which can present with a delay reaction, and some of the medication can present with an obstructive injury. And some drugs can get more fibrosis type rather than hepatic type. And some of the drugs can affect the veno-occlusive disease. So DILI can present with the different types of liver injury. So when hepatocytes and biliary epithelial cells are damaged, the first thing which would happen will be an innate immune cell activation. The dead cell or dying cell, they will release a lot of molecules, which will include DNA or the nuclear factors, and that will start attracting the innate immune cell. And this will include monocytes, which are known as the Kupffer cell in the liver, and also the neutrophils, and also the natural killer cells. And they react on these cells, and then these innate cells subsequently secrete the cytokines and the chemokines, causing a cascade of reaction and leading to the more injury and then linking the innate immune system with the adaptive immune system. So the medications or the drugs not only causing the hepatocytes and biliary epithelial cell damage, some of the drugs can also activate the innate immune cell directly, and that can lead to the secretion of the cytokines, chemokines, and some of them, they not only attract the immune cell, they can cause the endothelial cell activation to recruit more cells, and some of the factor like TGF, they could activate the stellate cell, which will lead to the fibrosis in later time. So after the innate immune reaction, and the adaptive immune cells will play a role. And Guru and team already reported before that when we had a drug-induced liver injury, the drug can be processed in the antigen presenter. In the context of liver, it could be a monocyte, or it could be a dendritic cell. And this presented antigen with a MHC class 2 will prime the CD4, and these CD4 can become Th1 or Th17 to cause more damage. But if this drug metabolite is presented straight directly with the MHC class 1, they will activate the CD8 cell. So it depends on whether it activates with a class 1 or class 2, it's going to prime the different types of T cell. It's not only that, the injured liver will have a TNF receptor upregulated. That will include the Fas ligand and then also the trail, which will lead to the cell death. Either innate or immune reaction, these cells, they need to migrate and they need to home to the liver. So chemokine receptor interaction is really crucial. And we have shown before that chemokines such as CXCL10 is highly enriched in the inflamed liver, inflamed sinusoid, and that will attract all the innate and adaptive immune cell, which express the chemokine receptor, CXCR3. So this CXCL10 and CXCR3 pathway is crucial to get all these immune cells into the drug-induced inflamed liver. And we look at it before, is Dr. Faith Rickard, who was in Birmingham, look at the clinical data of the acute autoimmune hepatitis and drug-induced liver injury to see whether there is a biochemical or immune predictor. We could review that. And the number is a bit small. We look at around 25 on each arm. What we found is a DILI patient will have a higher bilirubin, and they will have also delayed resolution of the liver enzyme. Immunoglobulins will be elevated in both conditions because B cells will be involved as well. When we talk about the DILI and checkpoint inhibitor also need to be mentioned because we use a lot of checkpoint inhibitor these days, especially for the lung cancer and skin cancer. So PD-1, PD-L1, and the CTLA-4 blockade has been widely used and approved, but there will be a new checkpoint inhibitors like blocking the TIM3 and the TIGIT. What normally happens is these checkpoint inhibitors, they will release the brake on the affected T cell. But while the intention is to kill the tumor cell, some of these checkpoint ligands are also expressed on the hepatocytes, biliary epithelial cells, and sinusoid. That is the reason sometimes we got the untoward liver injury from the checkpoint inhibitors. And that is quite common. And then currently with the Nottingham team, we're trying to investigate the pathway. So we felt that DILI is still the unmet clinical needs. We still got a lot of things to do. And there is no single in vitro model or in vivo model which can investigate the DILI. So Amber from our lab and Stuart from Nottingham are currently doing the deep immunophenotyping to dissect the patient with the DILI, patient with the checkpoint inhibitors, and comparing with the acute autoimmune hepatitis to see whether we can find an immune predictor which will dissect the pathway which patient will be prone to the DILI. So these results, I'm sure that we can present in due course. So what we do in Birmingham is, in collaboration with the Nottingham, we collect these samples in the sodium heparin tube. We got the established 30-color CyTOF panel, and all the antibodies are metallic conjugated. And then we're trying to run it on the cytometry time of flight to see which innate subcells are elevated and which adaptive immune cells are involved. And we're doing it with the different time points and with a control in the different groups. So I think that would be an interesting finding and would be useful for the community. And not only the deep immunophenotyping, Jane mentioned about the single cell sequencing. To know exactly what is happening in the liver tissue is crucial. So either with a liver biopsy or 5-needle aspirate, the single cell RNA sequencing, and especially for the T cells and B cell, repertoire analysis will be crucial. And then we can do it with a CySeq, mapping out the phenotype, and this could stratify the patient group. So not only the blood deep immunophenotyping, tissue level investigation is crucial. And we also need to know the hepatic microenvironment. So that DILI patient will have a quite inflamed liver. Is it different from the acute autoimmune hepatitis? And that is we need to understand. So microenvironmental fluid analysis will be crucial. Generally, we know that interleukin-6 or interleukin-12 pro-inflammatory cytokines are enriched. And then some of the T cell survival factor like interleukin-2 is very low in the inflamed liver. Is it the same case for the drug-induced liver injury? That is what we need to understand. And that will create the pathway for the drug development. And we also need to know which cells are around which parenchyma or the epithelial cell. Are they CD4, CD8? Are they around the bile ducts? Are they around the hepatocyte? And this sort of investigation will be required from the biopsy with either immunohistochemistry or the CyTOF using the Hyperion methods. So applying the personalized medicine with all the technology using the deep immunophenotype, genomic, proteomic, and the metabolomic approach will be the way forward to treat the DILI patients. I will stop here. I'd like to thank Guru for giving us an opportunity to work together, and also the funding body and our collaborator. I would like to thank Amber, who is working together with Stuart for the deep immunophenotyping, and the rest of my team. And we all based in the University of Birmingham. Thank you very much.
And thank you, E, for a very clear exposition of a very complex subject and for sharing with us the exciting developments that are underway. So for our last talk in this session, I would like to invite Guru to step forward, and he's going to address us on the pharmacogenomics of DILI. Guru.
Good morning. Pharmacogenomics is the study of how genes influence a person's response to drugs. It can be both effects as well as adverse effects. We'll be talking about drug-induced liver injury today. My talk will cover the discoveries, what we have learned from them, and the clinical application. Going through the history of pharmacogenomics, initial phase is called biochemical genetics era, when phenotyping, by giving someone a drug, measuring the metabolites, and grouping people based on the phenotypes, and then inferring genetic background was done. In that way, already identification of genetic susceptibility to drug-induced liver injury from dibroxoquine, anti-TB drugs had already happened in the 1980s. Then came the candidate gene era, this time HLA association with halothane hepatitis, HLA association with coamoxiclav induced liver injury occurred in the 80s and 90s. We also performed some studies on diclofenac induced liver injury. We investigated what is called proximal events, drug-related factors which are influenced by genetics, like metabolic enzymes, genetic susceptibility to polymorphisms in transporters. We investigated and established their association with drug-induced liver injury related to diclofenac, for example. Then came the genome-wide association era, at which time we were lucky to have done the first genome-wide association study. And this was it. So we investigated a group of patients who had a drug-induced liver injury due to flucloxacillin, and large number of data from population-based controls available publicly for researchers. The data I'm presenting here is a larger set, which we did more recently, which included 197 cases of fluclox-induced liver injury and 6,835 healthy controls. If you are used to looking at this, what is called a Manhattan plot, x-axis is chromosomes. Every dot here is a SNP, or a single nucleotide polymorphism. And there are about 1 million dots in this graph. And this line where green dots appear is a threshold above which findings are statistically significant. So the y-axis is a log value of p-value. So the higher the number, lower the p-value, more significant it is. As you can see, on chromosome 6, there are a number of red dots, which all are HLA alleles, and the highest one is related to HLA-B 5701, and it's 37-fold increased risk of DILI associated with this, and a very strong association it is. And so we found that drug-induced liver injury, at least flucloxacillin-induced liver injury, is strongly influenced by allele in HLA class 1 gene, which is HLA-B star 5701, which is the same genetic polymorphism which is associated with abacavir-induced skin reaction. I'll come to overlap in a minute. Next landmark, not that this is the next GWAS that we did, next landmark is to identify that the same HLA allele, HLA-A, another class 1 molecule at this time, star 3301, was associated with cholestatic stroke, mixed form of drug-induced liver injury from a number of drugs. So in this study, we took away flucloxacillin and coamoxiclav cases completely, because we didn't want them to almost overwhelm the HLA association and then dilute the effect of other drug-induced liver injury. You still see lots of red dots and strong association, about 5-fold risk, with a very low p-value in relation to cholestatic and mixed form of drug-induced liver injury, not associated with hepatocellular form of liver injury. When you go to the top 10 drugs which contributed to this signal, I've put in just 4 here: terbinafine, ticlopidine, fenofibrate, and sertraline. If you look at the structure of this drug, there is nothing in common between them. But they all are associated with, I would say, majority of them are associated with cholestatic pattern of liver injury. Sertraline can come with predominantly hepatocellular pattern of liver injury. So what does this data tell us is that perhaps the proximal events, drug-related events, are different to these drugs. As you can see, the metabolic pathway are quite different, but common feature is that they all have gone through some hepatic metabolism. But the distal effect or final common pathway, if you want to call it that way, might be influenced by a common HLA association, which again stresses that whatever the way drugs start the process, eventually injury, closer to the injury, there is perhaps one pathway which is common, which might be adaptive immune response. Next is the overlap between adverse reaction in different organs. This is carbamazepine-induced skin injury. There are a number of cutaneous adverse reaction included in here, as well as drug-induced liver injury. It's the same HLA, again class 1 molecule, HLA-A star 3101, 18-fold association with skin reaction, 7-fold excess risk from liver injury. Both are statistically significant, which again tells you that from between drug-induced liver injury as well as cutaneous, what is deemed hypersensitive reaction, again, there is a common pathway or probably a common pathway. If you look at population stratification figure here, gray is population-based controls, red is a form of skin injury, which is Stevens-Johnson syndrome. Green, there are very few here, which are DRESS syndrome. Yellow is drug-induced liver injury. So the distribution of these cases are overlapping with controls, and then there is a clear mix between skin reaction as well as liver reaction. Again, establishing a hypothesis that these are driven probably by common mechanisms. Finally, most recent study, which involved the largest number of cases of DILI, collaboration between European and US based researchers, over 2,000 cases, over 12,000 population-based controls, and first time we picked up non-HLA related signals, which is polymorphism in gene, which is called PTPN22 with an odds ratio of 1.44. And interestingly, this polymorphism is already associated with multiple autoimmune related conditions: type 1 diabetes, rheumatoid arthritis, systemic lupus erythematosus, Graves and Hashimoto's thyroiditis, vitiligo, and Crohn's disease. Multiple organs, similar mechanism. And it codes for tyrosine phosphatase, which influences regulation of the immune system in general. Again, strengthens the hypothesis that adaptive immune response may be underlying drug-induced liver injury. So, what did we learn from genome-wide association study? First thing is that we could join some dots and then come up with a putative pathogenetic pathway. So, drug metabolized generally or quite commonly reactive metabolites, but body's defense mechanism turn them into stable metabolites and they are excreted. Small number of people produce excess reactive metabolite, which might cause subclinical liver injury, which may not generate in itself clinical liver injury, but it releases some of the substances from the injured cells, say hepatocytes, or some of these reactive metabolites might bind to the proteins, intracellular protein, or when it's released, might really bind to circulating protein, forming covalent adducts. And these adducts reduce function of protein and might cause cell injury, hence liver injury, and again might release some signals, what are called danger signals, cytokines, which are cofactors triggering immune mechanisms. but eventually either circulating adducts or cell generated altered peptides trigger adaptive immune response. So reactive metabolite covalent adducts presented by HLA molecules, class 1 if they're on hepatocytes, or class 2 in antigen presenting cells, trigger immune mediated reactions with the loss of immune tolerance related to non-HLA genetic polymorphism. It might precipitate overt clinical drug-induced liver injury. So this might be a putative pathogenic pathway. How do you apply it to clinical practice? Like any other test, you always have a pre-test probability on this x-axis. Then use a test. Use it either its negative predictive value to rule out or positive predictive value to rule in a diagnosis, and it will either lower the likelihood. If you start with 50% likelihood and pick up a negative predictive value, it'll drop down to 25%, or if it's a positive predictive value, it is increase it to 90% and you come to a diagnosis. This is no different to any other disease we manage. If you compare to what kind of tests we use and how does it compare with the HLA-based test. If you think of autoimmune hepatitis, where we always ask, even if the suspicion is very, very small, we ask for ANA, SMA antibodies, immunoglobulins, and anti-alkaline antibodies. This is almost a panel, okay? If you look at how many normal people in certain age groups might have it positive, it's substantial. Actually, 15 to 24%, more than 40-year-old, higher, will have positive ANA. And in autoimmune hepatitis, not everybody has got ANA positivity. Based on 1,000 patient-based audit in autoimmune hepatitis from UK, it's anywhere between 60%, actually, and in literature up to 75%. SMA, 40% plus have got some form of SMA, and less than 60% have positive in autoimmune hepatitis. Immunoglobulin is a bit better. 5% of the control group or normal people, and 85% or more of autoimmune hepatitis have this. And liver kidney microsomal antibodies have got very low positivity in normal control, but also low positivity in autoimmune hepatitis. If you compare to DRB1, 1501, 20% of the normal healthy population have this allele, while close to 60 to 70% of people with autoimmune co-amoxiclav-induced liver injury have got it. So this is comparable to ANA. Flucloxacillin as good as immunoglobulins. So 6% in normal controls, nearly 85% or more in flucloxacillin-induced drug-induced liver injury. Similarly, minocycline, and there are over 20 drugs which we currently use who have got HLA association. And cost is not an issue either. If you look at the antibody profile that we all do thousands of times over the practice, they cost 21 pounds in UK currently. HLA genotyping, specific locus will cost 35 pounds. So cost is not really an issue. How do we use it? I'll give you a few examples. So this is a 31-year-old man who came with jaundice and itching for a week or so, and he was taking some supplements to build the muscles. It's called JAK3D, and as with most supplements you get over the counter, this was smuggled to a prison. This guy was in a prison. They still were able to smuggle these things, and he was on it. And he was on it twice, and previous period, also he had some raised liver enzymes. But incidentally, he was also on the same 2 episodes, he was on flucloxacillin for skin infection as well. The most recent time, he was on it for 4 weeks prior to it. So you know there is a latency between fluclox treatment and the injury. So it was plausible that one of them could have got it. It was jaundice, he had a big rise in ALT. Immunoglobulin level was raised to make it even more challenging to separate. It was negative for all the serology for virus. ANA was negative. He was SMA positive. Do a liver biopsy, has got portal inflammation, some interface hepatitis. And that is, again, not specific. And we do a HLA-B 5701, he is negative for this. If you look at in this context, negative predictive value of flucloxacin-induced for fluclox-induced liver injury of 5701 is 99%. So we excluded it as a possibility, and we asked him to stay away from JAK3D. And we know for a follow-up period that he hasn't had any further episodes of exposure or injury to it. 77-year-old woman, metabolic syndrome, and she's on antihypertensives, omeprazole. She's been on atorvastatin, started in 2016, and he's been on it for nearly 3.5 years. So long period of exposure. She comes with very high ALT, 1,800 and above, and she had a normal ultrasound, negative autoantibodies, and all the virology screen negative. Biopsy showed features suggestive of autoimmune hepatitis. But we know that injury due to statin sometimes can look like autoimmune hepatitis. If you look here, lobular inflammation, hepatocyte rosettes, amperipolysis, plentiful of plasma cells. So has she got autoimmune hepatitis? This is the follow-on blood test when atorvastatin was stopped, improved substantially, still not entirely normal alkaline phosphatase. So she was being followed up. And during the follow-up, her ALT started going up again. ALT was 500 this time, had come down and starting to go up now. Immunoglobulins are still negative, autoantibodies are still negative, and we did a genotyping, and she's positive for a HLA-DRB1 0301, not positive for 0401. These two genotypes are associated with autoimmune hepatitis in genome-wide association studies. So she probably has got autoimmune hepatitis, and she started on prednisolone. So we had done it well before she had reached the peak, and this is another indication and time where HLA genotyping can be helpful to tell the difference between DILI versus autoimmune hepatitis. Third one is 21-year-old student presented with 6 days jaundice. She was exposed to Comoxiclav for a boil on her back short while ago. Hepatocellular pattern of liver injury, series of blood tests negative, excluded paracetamol overdose, normal imaging. She's starting to get coagulopathy already. About day 10, she started developing encephalopathy. She had to have a liver transplantation. Before, we did a transjugular biopsy, which was similar feature post-transplantation. If you look at the retic stain here, there is a small island of viable cells. Rest of it is all collapsed liver. Of course, there is some inflammation, but most of it is panlobular necrosis, which is typical of drug-induced liver injury. And she had HLA typing because she was having a transplantation. And HLA typing showed that she was DRB1 1502 positive. So 1501 is a common allele in Caucasians, but 1502 is common in Asians. This girl was from India. So this is about anywhere between 7 to 15% positivity in Asian population, but 0.7% in the Caucasian population. So we looked at more about the structural differences between 1501 and 1502. If you look at the structure, this one is 1501, this one is 1502. And this is the peptide binding groove in 2D. You can see this is where the amino acid is, not much different. This is the peptide binding groove in 3D. You can see this purple patch here and a green patch there is where pocket 1, where the peptides bind to. That is where the variation in the one amino acid exists. But overall, the shape of the groove hasn't changed very much. This color map tells you polarity of this. In other words, it's alkaline or acidic. Again, not much difference. So one change in amino acid does not change the ability of this peptide binding groove to bind to a peptide, which might be drug altered peptide. So we concluded that in Asians, probably 1502 behaves as good as 1501 and is supporting the diagnosis of drug-induced liver injury. Incidentally, about 6 months after this patient, another Asian, Pakistani born this time, had come with Cormack's curve liver injury, again had liver failure, again had explant investigated, and had a HLA typing. He also had 1502. So in 6 months' time, we saw 2 patients, both from another ethnic group, who had DRB1 1502, which was associated with Cormack's curve-induced liver injury. So this HLA typing is supportive of the diagnosis. So clinical application, as I see it, is that its negative predictive value of most of the HLA genotypes to rule out a particular drug-related liver injury is over 90%, certainly in some cases over 95%. So when there is a doubt between 2 drugs, and these are life-saving drugs like antibiotics, you can't just not use them when you have got a serious infection. So you need to be as precise as possible identifying the drug, and that is one way we can use the HLA typing. You certainly need to really diagnose autoimmune hepatitis accurately, and when there is a doubt, you can use genotyping. There are certain HLA types that are associated with DILI, and there is an HLA association with autoimmune hepatitis. In fact, the original criteria for autoimmune hepatitis diagnosis, the full form of autoimmune hepatitis diagnostic criteria did include HLA type, and in selected circumstances, it is useful telling one from the other. Finally, in selected cases, HLA genotyping can be used for its positive predictive value to strengthen the diagnosis. Ideally, I'll talk about it in the final session tomorrow, what the future for a polygenic score is in preempting as well as identifying drug-induced liver injuries. So genetic tests, at best, we can say, has got a good performance characteristic features, but predominantly driven by negative predictive value. But if you add to that drug-related factors, as well as other host-related factors in addition to genetics and some comorbidity, you might be able to create an algorithm which has got a very good predictive value. And this might be used in preempting drug-induced liver injury when we have got easily accessible genotype available. Thank you very much. I thank all my collaborators who are based all over Europe and the world. Thank you for supporting us, and all my funders who have supported my research over the years. Thank you very much.
Excellent talk, and fascinating to see the early application of the genomics to the clinical scenario. I hand over to Ramazan now.
Yeah, thank you very much. Also thank you for all speakers for their great presentation. We have several questions and we have planned time. Marsha, I also shared the all question with chat. The first question to go to Jane from the Maria. She's a hepatology pharmacist. She's asking that if the Pro-Euro register contains information about which drugs are more involved indeterminate delays? Jane?
Oh, that's too many. Jane?
Jane, yes.
Hi.
Could you please yes.
Hello. So yes, we do record each drug that we find to be the causal drug. So they're all being collated in our database. And I think once we reach our recruitment target, we'll be able to analyse those in more detail. But certainly we see the general ones that have been widely reported before.
Okay.
And I think that possibly what the pharmacist is asking is, could she use your website as a resource for looking for information about drugs, a bit like the liver tox database? I think that's possibly what the question means.
Okay. Yes. So at the moment, we don't allow other people to access the data because it has to be kept securely. So we'd need to apply to us and we could answer those sorts of questions. So no, it's not an equivalent of the liver tox database. It's not intended to be like that.
Okay. The second question from the Professor Tözün, and she's asking you to Jane. The question is, the adjudication panel is made up of leading experienced hepatologists from, she's saying great talks. And how is the composition of the adjudication panel? What's their specialization and how many experts are there? She's asking this question.
Yes. So that's good we involve all of our centres in the adjudication process. So we have monthly meetings and we invite all of the sites to participate. We obviously make sure we have at least 4 hepatologists present to discuss the case, plus the person who's presenting, who recruited the patient as well. So it's done by a panel from our pool of researchers.
Okay.
Okay, we have an interesting question here. I'm not really sure who we'll address it to, so I'll throw it out to the entire panel. Can drug-induced autoimmune hepatitis lead to cirrhosis? And how do you define chronicity after an acute DILI? Perhaps we'll get Guru to pick that one up.
Yeah, sure. Drug-induced autoimmune hepatitis itself is a challenging entity, to be absolutely sure, because ideally the condition should have distinct features. At the moment, what we choose to call drug-induced autoimmune hepatitis are the conditions where there is clear-cut causality assessment, at least at the time of onset. Then it resolves without immunosuppression. But when people are ill, you can't really kind of contemplate not giving them immunosuppression. Then if you did give, and you had strong enough suspicion that this might be drug-induced, like minocycline causes things which you just can't tell. Nitrofurantoin is another one we see often. In those cases, we either don't give the second line, like azathioprine, or if we did give it, whenever the physician feels confident enough, they have resolved the inflammation, we give just monitoring without immunosuppression. If you follow these patients, autoimmune hepatitis patients, about 4 years, 85% will relapse in some period of time. If you follow them for 2 years, about 65 to 70% of them relapse. So our criteria is decided on either they should resolve without any immunosuppression and don't come back, or we should have not given immunosuppression for past 2 years or so, and they didn't come back. So that is how we diagnose. Can it happen? I think I can go back. The best study comes from Einar Johnson. I think it's published somewhere around maybe 2010 or so, Journal of Hepatology. What he did was he had a, I think, Swedish database where he had 700 people who had jaundice, and they were all deemed drug-induced liver injury. He went back almost over 10 years follow-up, 15 I think he had follow-up, and then saw what happens in the database for these patients. I would say 3.4% or something, maybe about 23 people had either decompensation or hospitalization. And of these, 20% of these, which is about 7 patients, I think, recall, had a diagnosis of autoimmune hepatitis. So which means that you can plausibly say, if there was a best evidence to say, yes, they can trigger drug-induced liver injury, and they can trigger autoimmune hepatitis, and this can behave just like any other autoimmune hepatitis, that would be it. So what we really need is a superlative database study where we have a cases and a controls and then demonstrate that drugs are associated with bona fide cases of autoimmune hepatitis, which behave just like autoimmune hepatitis in every way, which is absolutely plausible. I mean, I must say that I mentioned this hypothesis in 2008 when I spoke in NIH. There was a lot of question on chronicity, which I had described first time in 1999, I think. So it is plausible because we still don't know what the antigen is for autoimmune hepatitis, do we? We have a lot of hypotheses, but we don't have it. So drugs might be one of them.
Yes. There is also autoimmune hepatitis, drug-induced autoimmune hepatitis session after this session. We will talk about this. The other question is Müjdat asking to Jane about the accuracy for register referral. Are there any ways to increase the accuracy for register referral because of 172 out of the 4,200 patients are registered as DILI?
Yes, I think it really highlights the challenge that we have on our hands here. So yes, from our adjudication, so as of 303 that we classified, it was that 172 were actually found to be genuine DILI cases. So yeah, it feels like to us it's a very inefficient way of setting up a registry. So it's very important that we try our best to collect as much information as we can at the time that they're recruited and try to understand the context of the DILI and make sure we understand what changes in their medications or the supplements that they've been taking. But really the challenge is that when they present, it's difficult to know what the cause is and how can we quickly exclude other etiologies without following them up over some time and actually seeing what other tests reveal. So yes, it would be good if we could find a good way to do this. So any suggestions and any new biomarkers for this would be really valuable.
Okay. Ahmed is asking, just a second. Yes, the GWAS data is very interesting in showing possible dysregulation in innate or adaptive immunity as a common final pathway. If that is the case too, why do we not see many cases of DILI also have simultaneously injury in other organs such as skin or other organs? E, would you like to say something about that?
Yeah, I think I could take that question. I think it will be quite exciting. That could probably link with what Guru mentioned about the autoimmune hepatitis or drug-induced AIH. And I still think that autoimmune hepatitis, even though we don't know the antigen, this is autoimmune process. The drug-induced is autoimmune. So the only way we can find out, dissect, will be with a new technology. I think we could compare the tissue level, like GeoMax or spatial transcriptome. Not only looking at the individual immune cell signature, we can look at what is happening at the tissue level. And that could probably would answer whether there is a chronicity or whether there is an innate or adaptive immune response. So I think when we try to do analysis, both blood and tissue level need to be matched. And these gene signature, we need to translate into the protein to find out whether that could help with a new pathway and the correct sort of targeted treatment. So there are a lot of things we could do because technology these days is fascinating.
Okay, thank you. Guru, this question for you from Fulya. Can genomic study help in acute hepatitis due to delay to manage in terms of duration of the result of the genomic test?
Yeah, well, if you have good facility, you can get genotyping fairly quickly. Just for example, abacavir and few drugs in non-Caucasian population are now licensed with HLA typing. So it's nothing extraordinary. Abacavir can only be prescribed if you rule out HLA B5701, and it can be delivered in about officially $60 Australian dollars. These tests are available, and 18 hours results. So it is possible. We can probably, if you ask Jane and pay her enough, she can do it in 2 days. So it is possible to deliver. The critical point is about antibiotics. Somebody is in ITU and has got a staphylococcal septicemia. So would you kind of stop giving a life-saving antibiotic or not? Same way, anti-epileptics. I would say it is important. This is not really, we don't have abundant antibiotics. People are worried about a generation where you will have resistant bugs, and we don't have any antibiotic to save us. So we need to use them carefully rather than checking them out. So in these circumstances, I think the efficacy of flucloxacillin for staphylococcus is excellent. So I would really use in such cases with all means, just to exclude a possibility that this is causing a problem.
Okay. I have a question also, Guru. In your first case, patient admitted to the hospital for delay. And patient mentioned that in his history, and he used the medication, he take the medication. Even that, we should send the test for the genotyping?
At the time, I don't use it routinely because in some cases, there is one drug and there is no alternative cause. You probably don't need it. We do it with a low threshold. There is genuine reason when I ask for it. And as you can see, there is a benefit. For him, it's for his next course. This is the point. There are diabetic patients who have got a foot ulcer who will need flucloxacillin in the future. So those are the ones. If I kind of condemn them with saying, well, don't use this, that, or the other, then they will run out of antibiotics very soon and then run out of foot or the leg very soon. So it is really such cases. I mean, I didn't really take up another case where I had a Comoxiclav person, and that patient had also osteomyelitis. So patient had a background of alkaline phosphatase going up, and then it shoots up and becomes jaundice. And is it Comoxiclav? How much is due to another drug? So those are the circumstances where there is any support I will use. So I think it is definitely helpful.
Okay. Marsha, do you have any question?
No, I'm thinking deeply, but I think an awful lot has been covered this morning and covered extremely well. I think this still remains a very difficult area clinically. And I was also interested in the fact that Jane said about the percentage of patients that are put forward in all good faith, but actually turn out not to be, by expert opinion, DILI. And that hasn't differed terribly much from the first series that Guru did in 1999 in the Nottingham area, which showed that, or I think it may be Newcastle area then, which showed that it was 47%. Only that survived the expert opinion. So that we haven't done terribly well in the last 20 years in terms of our diagnosis from a clinician's point of view of the DILIs. So it was interesting to see that percentage. It wasn't surprising. It's possibly disappointing, but it wasn't actually surprising. Jane.
Just to add a point is that number includes control group as well. This is a research protocol where we adjudicate, we enroll as soon as you think there is a possibility of delay. And if they on the investigation turn out to be alternative cause, they become controls.
Yes.
So just to kind of clarify that if you go through the adjudication where it is inconclusive, we are really have a low threshold to take away the patient because it's a research study. We need an absolute robust diagnosis. We take out about 15% to 25% eventually, where we can't conclude either it is a delay or it's an alternative diagnosis. So that is a kind of a number you can take it.
Yes, so you're being purer than you would be under normal circumstances, but it's still interesting, I think.
It is. You are right that we need a tool. I mean, this is why I say genetics is a tool which people reluctantly make some excuses not to use it. I mean, first of all, they say cost. Well, I'm telling you, you're already costing me by asking for this autoantibody panel hundreds, well, really, literally thousands of times.
Yeah.
But they are reluctant to say, well, we need more evidence. I mean, what evidence did you use these antibodies from? Evidence says that it is not useful. So I think that is one thing you can improve. And then second is absolutely, we need something beyond this.
Yes.
And hopefully I'll see something tomorrow and then show you where we are heading.
Yeah.
One quick question I'm going to ask us, please, for the differentiation between the DILI and autoimmune hepatitis. In this case, how the course of the disease may give us any clue for more certain diagnosis? I mean,
Is it for me?
Yeah, I mean, for you.
Yeah, well, I mean, I personally, some point, maybe you or someone mentioned, maybe one of your speakers mentioned that we use everything for autoimmune hepatitis diagnosis, even if I don't suspect DILI, because this is a lifetime drug you're going to commit them to, immunosuppression, and it comes in all age groups. So their lifespan is impaired, even if you treat them adequately. So it's not really something you kind of trivially say, well, IgG is up, what else it can be, duck is a duck. So you start treatment. So I use every tool there is. So liver biopsy is exceptionally rare where we don't do a liver biopsy. And when there is any doubt, we still do HLA typing. Two is the follow-up. If you have a doubt, we still give a chance for them to come off the drug, monitor them carefully, and give them stay off the medication. So we need to do all that, and probably deep immunophenotyping, which Yi is mentioning, is heading that way. So we need more tools, which we haven't explored. We always look for biomarkers, means proteins we look for. We've gone to a genetics, we still haven't used it. Now you need to find cells which can tell you one way or the other. So that is where we need to head to and then get it nailed down a bit more closely. Marsha might have a view on this. What do you think, Marsha?
Well, as you know, I'm very pro genetics. I'm very pro everything else. And I would like to see people being less scared of these new and advanced technologies, because that's where we're going and we have to go there. And the more we go there, the more the price will come down. So, I'm very much with you on this. I had a question I wanted to just briefly ask Jane, if she's able to give us. Out of your first batch that you have actually adjudicated, what's coming out in the ladder? I mean, what's the top sort of classes of drugs that are coming through? Can you give us that?
I'm afraid I can't. I don't know if Guru can give you an idea. And I think tamoxifen is probably up there, and fluvoxacillin. Can't think of any more off the top of my head because I don't attend all the adjudications. So
yeah, antibiotics are still high, Marsha, but nitrofurantoin joins the queue. Comoxiclav, because it's the commonest around Europe.
Yes.
I would say biologicals. You get quite a few infliximab ones, mainly from Iceland. I don't know whether it's to do with some ethnic variation in HLA distribution or not. We have found an HLA association with infliximab. And then checkpoint inhibitor. Checkpoint inhibitors are now becoming more and more and more, and probably will beat antibiotics very soon.
It's the price you pay for introducing new agents, isn't it, actually? Because
Exactly.
yeah.
Okay, Marsha, we answered all questions that we have, and I guess we should close this session.
Yes.
I would like to thank all speakers for their kind contribution, and I thank you for your sharing this session together. Would you like to say something?
No, I've just been fascinated by the whole morning. This is a topic that people fear to tread in because it's diagnostically so difficult, but it's wonderful to see what's going on. I'm particularly thrilled about the registries, both the European one and the one that's being set up in Turkey, because I think that's where the future is. We need more research before we're ever going to be able to move forward as physicians in the clinical setting. So an amazing morning, very, very exciting. Thank you very much indeed.
Thank you very much. 10 minutes breakout and see you 3:40 p.m.
Okay. Thank you very much indeed.
See you in 10 minutes.
See you in 10 minutes.